So coronavirus, I'm going to talk a bit about what it is, how we've used our past experiences with other coronaviruses to shape what we're doing now. Hopefully allay some fears, because that's the most important thing at the moment. People are understandably very scared because we have a new disease that we haven't seen before, although we have seen similar before. But people are frightened, very frightened about it, and I really get that, and it's really important that you're not, because if you are not completely confident and you are worried, then you may not be concentrating, or your mind may not be completely on your job, and that's when mistakes can happen and slips can happen. And and here in the Trust, we really want people to be as safe as possible, and it's in our interest and in your interest for this to happen, because we are going to need you to look after the people that are going to be coming our way, and we need you to be safe as well. What I really want you to do is watch out for fake news. There's a lot of it around. Facebook, I'm afraid, is a nightmare, okay, for it. So a couple of days ago, somebody was saying, oh, well, there's 3 doctors on intensive care unit at St George's, So Mike Aisbit, the A&E consultant, rang up his friend who runs that unit, and there are no doctors in intensive care unit at St George's. So there's a lot of fake stuff. If you want to follow or get some good, up-to-date information, Twitter actually is the place to go. And if you follow people like at SM Hopkins, who's the infection control lead at Public Health England and also an infectious disease physician at the Royal Free, you'll get really good information. If you follow me and have a look at who I follow, then you'll see people publishing, putting on quite new scientific information as it becomes available. And new stuff comes along all the time. And I've changed this talk overnight, for example, with a couple of extra little bits. Okay. So there are a number of respiratory viruses, and you'll see that coronavirus is already on this one because it causes the common cold. Okay, there are 7 different types of coronaviruses, 4 of which regularly circulate anyway, but there are a number of other different viruses. Influenza viruses, parainfluenza viruses, RSV, that sort of stuff. And so the respiratory viruses are not unfamiliar to us. It's just this is a new one that we haven't seen before. But we have seen something similar. And the problem with this is, why has it become so bad, is because at the moment there's no immunity to block transmission. So with influenza, every year Public Health England will look at what the flu strains that are likely to be circulating, and they continually circulate, and they will go for maybe a trivalent, maybe a quadrivalent vaccine, which maybe has 3 or 4 different flus in it, and that reduces the susceptibility of the population. So you give it to the high-risk people, the elderly people, and then you reduce the population of people who could get infection. But we have not got that, and I can't see a vaccine for months at the moment. Okay, so we have a population we assume are completely susceptible to this, and we have no vaccine. So therefore, the mathematical modelers have predicted where the disease curve could go, because it does seem to transmit fairly rapidly from one person to another. And I'll talk about how transmission happens and how transmissible this is in a while. But there's a lot we're discovering, and science is really rushing ahead. I mean, huge advances have been made in weeks that would have taken years a while ago. So we're finding out the incubation period is very much like MERS now, and we're finding that actually quite a few people have had it asymptomatically. So they sampled quite a large percentage of the population in Iceland, for example, and half of those who tested positive had no symptoms whatsoever. And there is a suspicion that we may have had it here in the UK. I think we have, to be honest, because if it started in China in October, November, the first flights coming from China were not in October, November. And if you talk to people, they'll say, do you know, I know someone who had this terrible cough and they felt like death for a few days, and they were in bed for a few days back in November, December. And some other mathematical modelers at Oxford did some modelling on that, and they suspect that possibly half of us may have had it already. But we don't know that at the moment, because the only test we're doing is a test to see if you have infection. So that's where the accent has gone on to antibody testing. Okay, so the government announced 3.5 million antibody tests yesterday. Boris said they'd be available within days. It's not going to be days, of course, but it is going to be soon. So Public Health England are validating them at the moment to make sure they are kosher. They do what they said they do. So are they sensitive? Are they specific? And if they are good, then we can use them for healthcare workers, and they're going to make them available to the public to buy if there's enough left. Okay, so that's important. So at the moment, we don't know whether the asymptomatic carriers will transmit but it's possible that if you're not symptomatic, so you're not coughing, you'll definitely transmit less. Okay? And knowing how the disease transmits is really important if we're going to try and reduce the spread. So these are called coronaviruses because they've actually got a crown or halo around them, so it's done on the physical look of them. They're envelope viruses, so viruses are either enveloped or non-enveloped, and non-enveloped viruses are things like norovirus, the tummy bug type ones. And envelope means that's very good news because it means it's easier to kill, so that's helpful. These coronaviruses generally affect the upper respiratory tract, and they have a big impact on society because, lots of people get colds during the winter and they're off for a couple of days, and if you're a man, you're off for a month. But they have a significant impact on society, but they continually circulate. That's the human ones. Okay, and you could potentially get secondary bacterial pneumonia, as you can with the influenza. But some of the new ones are zoonotic in nature, which means they've come from the animal chain and got into humans through mutations. And that's the ones we haven't had any experience of, which means we're completely susceptible to them. So there's 4 endemic human ones that continually circulate around the world. But the human zoonotic ones that started in 2002, the first one was SARS. Anybody remember SARS? Yeah. And then we had MERS in 2012. And now we've got this new coronavirus. And the virus is called SARS-CoV-2. Okay, because it's very similar to SARS. And the infection, we're calling the disease COVID-19. So they're both the same thing. So the organism causes the infection. And COVID-19 stands for coronavirus infectious disease 19. Okay, all of these came from bats. Okay, yeah. So the first one, SARS-CoV, came from bats and went to palm civets, which are like cuddly little cat things, and you can see in Chinese markets, mixed up with other mammals, got into the human chain. MERS went from bats to camels and then into the human chain. And this one seems to be bats, well, it is bats again, but it's gone through pangolins in this case to get into the human chain. And so bats are the reservoir of these coronaviruses that have the potential to get into us. But, flu viruses come from birds out in Asia, and they constantly change and circulate. So when you don't know what the illness is or the disease is, you can go on previous experience. So as soon as you find out it's a coronavirus that's probably zoonotic in nature, you then think, okay, what happened before? So reflect on what happened before. And SARS, 2002, global health alert by March 2003, from one hotel in Hong Kong, it went to 24 countries. Canada had a horrendous problem with it. Actually, a lot of healthcare workers, because they were not dealing with their PPE correctly. And their bad experience, has taught us a lot about how we use the PPE correctly when we're challenged with it. So you don't get the same sort of situation as that. Clinical picture, severe pneumonia, 8,000 infections, 1 in 10 mortality. Okay, very high mortality, mostly over 50 and male. So as I mentioned, it's come from bats and got into animals. But by 2003, it disappeared. So this did not spread rapidly from person to person. Okay, it was people with very close contact to an infected case, but it didn't really seem to contaminate the environment too much, although it did in healthcare. But it just disappeared, and we've never seen it since. MERS is slightly different, so that appeared in 2012, and suddenly they had this huge number of cases in Saudi Arabia, 1,000 cases, death rate, huge. Initially high, 30 to 40% of people died. Yeah. Big parallels with SARS infections in the way that it seemed to spread. Again, zoonotic, tomb bats in Egypt, camels, and in fact, when they tested the camels, 90% of the camels in Saudi Arabia had this. 2,500 cases, 35% death rate. So that's where people were really, really worried about this at the beginning, because if it transmitted very quickly and had a very high death rate, then we're really in big trouble. Okay. Actually, MERS never went away. You still get the odd case in Saudi Arabia, as the camel still had it. Most of the camel farmers have antibodies to it, so some of them had subclinical infections with it as well. They did do a camel vaccination program, but actually the Saudi Arabians imported a load of camels from Australia, which has the biggest wild camel population in the world, and there's no tomb bats out there, so they were all coronavirus free. And so that brought the reproductive factor, which we call R0, down to less than 1. And the reproductive factor is something you calculate when you've got an infectious disease. In other words, if I have it, how many people will I give it to? And that's really useful. So if it's 1, I'll give it to one person, and that person gives it to one person. It means it's not going to cause an epidemic. It will kick around, but it's not causing an epidemic. If it's less than 1, it's going to die out. Okay, so if it's 0.68, for example, if 100 people have it, they will give it to 68 people. And those 68 people give it to something like 42. And those 42 give it to 30, and it just declines. This at the moment has an R0 of about 2.5 to 3, which means if I have it and you're not, you're susceptible, which we think everybody is, but we don't know, then I give it to 3. And those 3 people give it to 9. And those 9 give it to 27. So you can see it goes like that. Yeah. So what you have to do is work out, okay, how can we interrupt this, which is why we're all in lockdown. So what you can then do is chart them out. So here's SARS, here's MERS and SARS-CoV-2 on the right, and you can see all the similarities, apart from the number of countries. 27 countries for MERS, 29 countries for SARS, 167 countries it is now for COVID-2, and that's because it was already spread well around the world before they actually put in the control measures. All bats, look at the numbers of cases though, 8,000, 2,500, 417,000. Incubation period is pretty much the same. At the beginning we're going with the MERS, which is the worst case, 2 to 14. Now we think it's more likely to be 2 to 7, the incubation period. Occasionally you get someone who's possibly 14 days, but they may have had another exposure in the meantime that you don't really know about. Infectivity started at 2.2 for SARS but dropped to 0.3, so that went away. MERS has dropped down to less than 1. At the moment we're 2.5 to 3. And there are some people who seem to contaminate the environment a little bit more. I take that with a little bit of a pinch of salt because it does depend on how well you decontaminate the environment around them. But that means then the treatment is the same, it's all supportive, there's no actual treatment as such, and the infection prevention for the same. And we know what worked for the others, therefore we know what will work for this. So it's droplet protection and contact precautions and face shields that are going to work for us. Now everybody gets very concerned about mortality rates, and I absolutely understand why. And you'll see in the papers, why is Germany 0.3% and we are 4.9% and Italy 9.2%? And that depends on a number of factors. So at the beginning in China, for example, it was 17%. But they were hardly testing anybody. They were only testing the people who came to the hospital who had severe respiratory disease. Okay, so if you only test those, then you get a high death rate because some of those are going to die. By the end, when they're doing all the testing of the people who are positive, the death rate is 0.7. So it will likely end up around that, I think. But at the moment, we're not testing that many. We're testing the people who come to hospital who are symptomatic. People who are self-isolating in their home, not testing. The antibody test is really going to help us work out how transmissible this is. So it's nothing like as transmissible as we feared, it seems, possibly. So the things that affect this rate is the number of cases detected by testing, varies by country, and I'll show you that in a moment. Selection bias means you only test the more severe, so that doesn't help. Sometimes, there is a delay between symptom onset. So if you test me now, I go into the figures as a case, but I don't die for 2 to 3 weeks, then there is a bit of a lag. So that will affect the figures, maybe more at the beginning, but not so much now because we've got so much data. Other infections, sometimes people will die of another infection. If we put people on a ventilator, we've got to make sure they don't get a ventilator-associated pneumonia. If they have poorer healthcare systems, what about the population demographics? Italy has the oldest population in Europe, although Germany has the second oldest population in Europe. And it's interesting to look at what's happening there. Sometimes people die with coronavirus, and maybe they had a malignancy, and that's actually what they died of, but they died testing positive for coronavirus, so it goes on the death certificate. So there's a lot of things that are involved in the death rate, and eventually we will get to what the true figure is, but at the moment that's all we have. If you look at what's going to happen going forward, the ICU provision, Germany has 29 ITU beds per 100,000 population. Italy has 12.5 and we have 6.6. So we have a quarter of the number that Germany has and half as much as Italy. That's not going to help. And also the age of those infected. And in Germany at the moment, the median age is 46. So that's a younger population, so the death rate is lower. In Italy, it's 63. Here it's 64. So it's the older people are more likely to get, to actually to succumb to this. So that also will skew things, and it may well be that in Germany it will move up up into the age groups. But also think about cultural aspects of this. So in Italy, The grandparents are very much part of the family. And everybody comes together for the family meal, and there's lots of hugging and kissing. My kids see their grandparents not once a month sometimes, once every 6 months. And when they do, it's all right, Nana. It's not arms around them as much. So there are cultural differences that maybe help or have helped transmission. And there's it's going to be some good information coming out of this. Just show you testing. Korea's been ahead of everybody. They test 550 people per 100,000. Australia have tested huge numbers of people. In the UK, we're doing about 100 per 100,000. America, 17 per 100,000 population. They just haven't been testing. Because it's going to go away in days, according to Donald. And they're all going to be working again by Easter. Yeah. So, symptoms. Okay, incubation period, you think, probably 2 to 7 days, peaking about 5 to 7. Similar to seasonal flu, that's the same sort of incubation period. Most people have fever and dry cough. Okay, and that comes on quite rapidly. Suddenly, oh God, I'm feeling terrible. Symptoms last about 5 to 6 days, at which point you'll either recover or develop more severe illness. That starts about day 7, which is shortness of breath, lung inflammation, pneumonia, and that's when they're more likely to come to the hospital. Okay. So 88% of people get fever, so that's not 100%, so some people don't get a temperature. Yeah. Dry cough, 68%. Then you've got the usual viral things like fatigue, muscle joint pain, sore throat, headache. Shortness of breath, though, you don't get with flu so much. Sputum, I'm wondering about because it could be a bit of a red herring because people have got respiratory problems will be producing sputum anyway. So there are differences in the symptoms. So if you look at this, there's a nice microbiologist in New Zealand who actually is an artist as well, and she drew this. So you've got COVID here, flu and cold. So dry cough, COVID and flu, but not so much a cold. Fever, COVID and flu, not so much a cold. Runny nose, no, useful, but runny nose a lot with a cold. So if people have got a terrible sniff, you see them blowing in their nose all the time, then they've got a cold. Yeah, sore throat, not so much as a cold, but breathlessness is significant. Yeah, and then headache and body aches, etc., etc. Notice the top right. Diarrhea, no. So we did not need to empty Tesco's of toilet roll. And in fact, we should use Tesco's as our indicator of communicable diseases in future. So if all the toilet rolls are gone, there's an upper respiratory problem. And if all the nasal spray is gone, then it's diarrhea that's circulating in the community because people seem to have got it completely, well, they don't know their from their, yeah. Anyway, yeah. So severity of illness. Now, this is a bit tricky because we don't know about what we don't know, and the antibody test, when that starts, will tell us about the undetected, because we found that a lot of people have no obvious symptoms. They're talking about Prince Charles. He's at home, self-isolating. He's actually classed in the papers as working from home. So he's all right. And most people are like that. 81% of people, the cure is time, or going to bed for a few days if it's a bit more severe. But 14% get a big drop in their oxygen saturation, they're breathless, they need oxygen. They're going to come to hospital. And 5% will need ITU. So 5% of the whole population who suddenly got it very quickly means our health system collapses. So that's why we're doing what we're doing, okay? Because children do get it, but they get mild disease in general, and that's a generalisation because there's always a spectrum of every disease. Some kids will get it and get no symptoms whatsoever, and some will get it a little bit more severely. Okay, it's more severe disease in older people, especially if they are diabetic, have heart disease, chronic respiratory disease, and many old people have all of these. And that's what happens as you get old. All your systems start not to work very well, and you get susceptible to something that's going to take you out effectively. Immunocompromised. People have been very cautious with the immunocompromised, but I've read a very good paper this morning that says that illness in the immunocompromised is no more severe than it is in the other population. So that's a little bit reassuring. We'll still be careful with it, but that's an indication that if you are immunocompromised and on chemotherapy drugs, then you aren't going to suffer as badly as we feared, so that's helpful. Overall, we probably think less than 2% of cases will be fatal at most because of the lack of obvious symptoms. We don't know that number yet, and we won't know that number yet for a year or two until we get the antibody test. That's why we get a very low death rate from flu. It's because they do antibody testing at the end of the year, looked at who had flu, look at all the people positive in the population, you get a low death rate. But we're nowhere near that yet, and that's of interest later, possibly. So calculating contagion, as I said, you use the R0. So if it's less than 1, it'll go away. If it's 1, it'll just tick along. So we need to get it to less than 1. But if it's more than 1, it will just keep going until one of 3 things happens, or all of them. In other words, most have had it, and to really stop transmission, 80% of us need to have had it. Or there's a vaccination, which means it stops it, or we put in control measures. And at the moment, we don't know about that. Now, 50% of us have already had it, which is a hugely optimistic view. If we have, then that's really going to help. Vaccination is months away. So what we're now doing is effective control measures, which in the hospital, when we're dealing with people, that's use of our PPE. But outside hospital, that's the social distancing, okay, which people were not doing particularly well, and potentially still aren't, I don't think.